Hello, my name is Kathleen Lisson. I'm a lymphedema therapist in San Diego, California, and I want to share some things that I learned from the recent NLN conference in Nashville, Tennessee. So I have my 2 pages of notes. I'll be going over 4 main concepts that I learned that we kind of talked about that were my big aha moments, and then a lot of clinical pearls. And I'll share why each of both things were used in the conference during this presentation. Okay, so the first concept was from Linda Roherty, and she was doing this excellent presentation about truncal lymphedema after breast cancer surgery. And that is that fibrosis is a biological bandage. We know it's scar tissue, but this concept that it's a biological bandage, that's our body trying to do something, and it's not very effective. So that's why we're trying to help the body with the fibrosis. But the fibrosis is there for a reason, and that reason is unresolved inflammation in the body. So inflammation is the spark, and fibrosis is the flame. So if you're like me and you're always trying to help people with fibrosis, learn more intensely about fibrosis, that was a concept that I brought home. Number 2 concept is on the central lymphatics. So we had an excellent presentation by Dr. Doublestein on central lymphatics. He talks about Sibson's fascia as something that we're using manual techniques to try to help. He talked about exhaling with pursed breathing. So teaching the patient to not just inhale with the diaphragm and the muscles, but also to use forced exhalation as a way to help with the lymphatic system. And then we were talking in the pediatric lymphedema class about how we will use instruments like this one, like blowing bubbles, pinwheels, to teach children to do that forced exhalation breathing. That's also so important. He also, when we were doing some manual techniques on the trunk, the concept of sinking down into the first depth, that first resistance, and then working from that part of the tissue. And that is something to really think about if you're kind of stuck in this paradigm of it has to be like light as a feather, that if we're working with the central lymphatics, we are sinking deeper into the tissue. And then some physical postures that will help with central lymphatics. As a yoga teacher, that they really looked like some twisting spinal twists, like a supine spinal twist that we would do with yoga, or a cobra pose that we would do in yoga. And the pursed breathing might also be like Kapalbhati breathing that we do in yoga. So that might be, and I mentioned this in the class that I was in, that might be something that we can give the client as part of their self-management techniques. If they already enjoy yoga, if they're already doing yoga, which so many of our clients are, because they picked up yoga for the stress reduction during their cancer treatment, that these yoga techniques that their yoga teacher or their current yoga practice might have can also be done with the intention of helping with the central lymphatic issues. Okay, number 3 is this difference between our old term of talking about compliance and maybe our new term and idea of talking about adherence, and thinking deeply about what the difference between making a patient comply with something as far as self-management and increasing the patient's adherence to their self-management plan that they chose. They had a hand in choosing. And that's the concept, is that patient buy-in is essential. If we're helping clients with lymphedema, the patient buy-in is essential. And then another little thing to give nuance to this concept is we were talking about both in the adult population that might have dementia, early onset dementia, and a caregiver, and then also the pediatric population that has a caregiver because the young child cannot be fully responsible yet for their lymphedema treatment, that we're building in that buy-in, not just with the patient, but also with the caregiver. So this, I think, as we're going forward with lymphedema care into the future, we are going to have to pick up these skills of not just communicating the importance of the self-management techniques to the patient, but also how are we communicating it to the caregiver? How are we empowering the caregiver to improve adherence to the lymphedema treatment in the client? And then we went over the goals of treatment, both in the intensive phase and in the conservative self-management phase. And it's important that we always repeat them and we always listen to them, because the tendency is to just think that lymphedema reduction is about volume reduction and lymphedema management is about keeping the volume reduction that you got in the lymphedema intensive phase. And lymphedema treatment is more than just making that body part smaller. So the lymphedema goals of treatment are the limb volume, function and activity, skin health and infection risk, comfort and quality of life, support and adherence. These are the things that should be the goals of intense care of treatment. And then the goals for the chronic phase. The client is going to be controlling their volume. They're also going to be using the self-MLD techniques, self-management techniques to control tissue consistency. We're going to look at their health-related quality of life. They're going to be doing this lymphedema self-management to improve their health-related quality of life. They're going to be doing lymphedema self-management to improve their range of motion, improve their function, improve their flexibility, and to decrease their pain, decrease their fatigue symptoms. So if we're telling people your self-management is just to make sure that you have the same volume in your limb, it's not illustrating all the reasons why they're doing the self-management, why they are adhering to their treatment, as if you talk to them about your lymphedema self-management adherence is going to affect your volume and your tissue consistency and your health-related quality of life and your range of motion, your function, your flexibility, and controlling your pain, and hopefully improving your fatigue symptoms. And those are the 4 central concepts that I put. And then we're going to go into just little pieces of clinical pearls that I saw. So I saw this, I got this PinoFit off of Amazon after I went to the Foldy Clinic, and I saw this in use again with Linda as she was putting it on a fibrotic forearm, a fibrotic arm, and using this instead of injuring her body. She was using this and rolling something like this back and forward on the fibrosis to help melt it, to help soften it. And then using the manual lymphatic drainage afterwards to help move that tissue, to help improve that fibrosis. So I was glad I was able to see this. That is in my office, to see it in use on clients. And again, this again goes as information. If you are stuck in that paradigm of it has to be like a light feathers touch, that is not the manual technique that is going to help and be most effective against fibrosis. You need to think of addressing the tissue in different ways when you're feeling fibrosis. Okay, the clinical pearls. I loved these slides that I saw, so I wrote this down. The first one is, do surgeons refer proactively or only when problems happen? And that was, they didn't put surgeons in there, but I was thinking of lymphedema surgeons and also plastic surgeons. There's different types of surgeons, right? Are they going to refer to treatment proactively, or are they going to wait until someone comes in their office with a problem and only then offer resources? And we need to think about this as ourselves as clinicians, the surgeons we work with, the other doctors we work with. Are people getting to the lymphedema therapy too late because they're not getting with a medical professional that is going to proactively give them the resources they need before they need them? With the excellent head and neck cancer class, that concept, that clinical pearl, that eating is exercise. If someone has head and neck cancer, eating is their exercise that's going to be able to affect their tissue consistency. So if someone's eating, have them wear that compression, have them wear that textured compression, because that's when you're getting the movement that is equal to us using texture compression when someone is exercising with their limb that has lymphedema. If there are no manual techniques in what you're doing, you are a personal trainer, not a PT or an OT. And this was said outside of my scope of practice as a massage therapist, but I think it is so important to think about this. If you're not laying hands and putting hands and doing the massage and the manual techniques and the MLD and the deeper techniques and things that address their fibrosis, if all you're doing for the client is putting them in a garment and sending them off for exercise, and doing things that a personal trainer would do, then you are giving them the treatment only up to personal training. And then it begs the question, why aren't you just letting them go to the gym? Why are you taking their visits when they only have a certain amount of PT visits for the whole year? The concept that the clinical pearl, that the MLD that you do, the menial techniques that you do, is going to be firmer and slower if you feel dermal backflow. If someone has dermal backflow, then your MLD techniques have to be adjusted so they are firmer and they are slower. Gunter Close had a presentation where he talked about over the past few years and into the future, it's legitimate to estimate that there has been in the past a reduction in the amount of secondary lymphedema after cancer. We have gotten better at reducing the rates of secondary lymphedema after cancer. But what we're seeing now and what is in front of us in the future in America, because I'm in the United States, is an increase in what he called multi-causal lymphedema. And we also saw this in the presentation on billing and coding, that you should put, or they should, since I'm a massage therapist and I don't do this, but they were talking to PTs and OTs were talking together, and they said, if you're putting diagnoses, there's room for several diagnoses, and you have to see that your patient with lymphedema doesn't just come into your clinic with lymphedema. They have other comorbidities, and that is exacerbating potentially their lymphedema symptoms. So like I got taught these lymphedema protocols for someone who had perhaps just secondary lymphedema after breast cancer, but they didn't have other comorbidities. And now we're seeing more and more the lymphatic system is being affected by several different conditions at the same time. So the treatment has to take in account those several different conditions, especially, and this is more billing and coding and really less massage therapy, but it's good for us to understand the concept that if someone has early onset dementia and a caregiver, the way that you treat them has to be different, because you have to talk to the caregiver and you have to give them self-management techniques that they can do by themselves or with their caregiver. We had two Gunter Close recommended 2 research articles in his presentation by Dr. Doublestein, was an author on both of them. One was Don't Throw MLD Out with the Volume, and the other one was Efficacy of MLD Estimation of Truth, culled from the literature. So I am going to try to put the links to those in the description box of this YouTube video. So if you're on YouTube, you can see the description box, and hopefully I will be able to find you at least the abstract of those 2. But he said it's very important to read those presentations on MLD research. And then the final clinical pearl, it's great to see this in on a slide that we can kind of understand that it's not just our preference, but it really should be part of any surgeon's protocol. But for lymphedema surgery, the patient should arrive to surgery fully decongested. The patient should not have swelling that has not been addressed by CDT or uncontrolled swelling on the day of their surgery. That should be their prehabilitation, should be getting decongested, giving that surgeon the best limb, the best part of the body, the most decongested part of the body as possible for the patient. So that was my concepts, my clinical pearls. This was from the NLN meeting in Nashville, Tennessee. It was fantastic. It was a fantastic weekend of education, 3 days. I am so glad I went there. And if you're not a member of the NLN, definitely become a member of the NLN, especially if you feel like you don't have all the tools you need to be a lymphedema therapist. They have several groups with regular webinars where you can connect with fellow therapists and you can ask the questions and get the answers that you need to feel confident in treating clients with lymphatic diseases. Thanks and have a great day.